This tutorial is going to cover Randy's treatment journey with Dr. Olson. Dr. Grant Olson is a KOL of GuidedSMILE from Springfield, Missouri, Innovative Dental. He's a coach, trainer, and aficionado of GuidedSMILE. Randy opted for a double arch chrome surgery, and this video is going to go through the full treatment protocol for an edentulous maxillary with an opposing dentate. So let's go first with the records. Randy already had a denture and it fit. He was a patient of record, so he took care of his denture, made sure it had a reline, make sure it fit. And then doctor performed the dual scan in occlusion. You can see the little marks here, right? The markers for the dual scan. And when you do a dual scan, you always do it in occlusion. So even though this is a double arch and the lower is dentate, the patient is going to be biting, chin on the chin rest, scan the denture in the mouth, scan the denture by itself. And both times you scan, it'll have the radiopaque markers, which you can purchase from GuidedSMILE. You can purchase them from your lab or from suremark.com. And the dual scan, the 2 CTs are uploaded to your laboratory, and they are sent along with the normal photographs, right, for GuidedSMILE: left, right, center, retracted, and occlusion, and then some smiling photographs, full face, full smile, lips at rest, and then profile pictures. Just follow one of our records checklists for that. And the dual scan would normally be the record that you would send along with a physical bite and an opposing. However, we're going to show the digital workflow, which is how Dr. O performed this case. So what doctor will do, what team will do, is we'll take a 360 scan of the denture. All right, there's marker, and then 1, 2, 3 here. So there's 3 on the inside, 3 on the outside. But this is going to be an iOS scan of the denture, 360. All right, this gives us a perfect surface as opposed to just a CT scan of the denture. This gives us a perfect surface to make the pin guide. All right, so you scan this 360, then you put it back in the mouth and you scan the opposing. All right, and then just imagine the denture is now in the mouth, scan the opposing, and you scan the bite, and this will bring the denture back in the mouth. You see, this is just a bite scan, right? It's a hollow shell. All right, but when you scan this in the mouth, it will pull the denture in, and there you are, upper, lower bite. This is the ideal impression for a denture opposing a dentate. And then based on the records, we will prepare the case, plan the implant positions to our best ability, and then meet doctor online, plan the case, fabricate the guides, and then we go to surgery. So I won't go through all the details of how we go through that process, right? But send the guides, send everything to surgery, and then Dr. Olson was kind enough to document the full upper and lower surgery. And so that's what we want to go through. Dr. Olson is going to perform the upper surgery first, and on an edentulous case, doctor will try the pin guide in and make sure that it fits, against the opposing. Now, in this case, we made the pin guide, right, which is a duplicate of the denture. We made the pin guide with an integrated opposing bite. It was requested by doctor. Most of the time these days we don't, because the dentures really drop into occlusion. But if you want this integrated bite, then please request it on the RX, and then you'll know that the denture is fitting the tissue, and then under anesthesia, you can manipulate the mandible, in this case mandible, into this integrated bite. Now this case, we did not have the window in the palate, but normally there's a large window here so that you can inspect visually that it is seated, because sometimes you get some inflammation from anesthesia and you may not be able to get the denture seated for a bit of time while it dissipates. All right, but the idea here is that you'll lay your labial flap, as we're going to show, the crestal incision, labial flap, then you'll seat the denture, put the patient in occlusion, hold the chin firmly, with the patient basically biting in their denture, but they're biting in the pin guide, and then you drill and pin, drill, pin, drill, pin. All right, as you'll see here. So denture has been tried in, and then there is the crestal incision is made. All right, so literally right across the crest. You want to leave the distal palatal side of the crest intact so that the denture has a nice firm seating area, as opposed to just the palate. You want to have support for the denture around the palatal area of the ridge as well. All right, so flap forward. This might be a very large flap if there's some bone reduction. There's a little bit of bone reduction on this case. Won't go through every detail of this full surgery because it's long. It's a couple of hours long for both arches. I just want to share just some of this technique. It's always a two-tool technique, right? One tool, whether it's a Minnesota or here a spatula, just hold the tissue back while the other releases from the bone. All right. Then the pin guide is seated. Now, this part is critical. You can see doctor is making sure that the tissue, the flap tissue, is apical to the fixation base. And you see doctors with a lot of experience with this always being very, very careful. Spatula the tissue up, move the tissue up, make sure you're not pinning through it, right? Because you don't want it coronal and getting in the way of your bone reduction, and you don't want to pierce it, right? So you just want to make sure that it's elevated. All right, now, team is holding the chin firmly through this entire process, which is very important. Now, you saw Dr. O, he drilled to about 2 millimeters short. You can see here, about 2 millimeters short of the of full depth. And he'll do it again here too. Now you can see the assistant holding the chin, making sure that denture does not move. Fingers on the denture, chin on the chin rest. All right, and stopping short with the drill and putting a pin in. So you never want to drill all the sites and then put pins in, because things can move, especially with a little bit of pressure here. All right, so those two existing pins hold everything in place while you're drilling the next site. All right, he's strategically leaving these pins short because he's going to tap them in with a surgical mallet. All right, and he's being very careful to stop short. It's very easy in the maxilla to just drop that burr, that drill all the way to depth, and then say, oops. Because often the bone is just not dense enough to hold the drill back. They're very sharp. Okay, so then he's going to use a surgical mallet, tap in the pins, and here he's using the end of a mirror. Right, take the mirror off, place the mirror handle on the pin, tap them in, and here be very careful that you're not over tapping. You'll know when the head of the pin meets the metal, the noise will change. The sound that it's making when you're tapping will change. And visually, you can also just stop when you reach the fixation base. if you keep tapping, you will move the pin guide. Might be just a little bit, might be a lot if the bone is not very dense. And now you've put the pin guide in a different position, which means your bite is off, your implants, your bone reduction, everything is off if that fixation base isn't precisely where it's planned. And that's what over tapping can do. All right, pins are in, pins are secure. I'm sorry, I hit a little rewind there. Next step is to unclick the chrome locks. All right, sorry about this. Moving around a little bit. You're going to unclick the chrome locks and take the pin guide off, and this is what's exposed. A little extra numbing here. This is what's exposed. So now you have a full visualization of where the bone is going to be reduced. I'm going to do a little extra exposure here, because with GuidedSMILE, it's only a labial fixation, right? It's not a full wrap. It's also floating. That metal is not touching the bone. It is labial to it, 2 to 3 millimeters. And so if you don't have this lingual apparatus, then your lingual flap can be minimal, just a little bit apical to the bone reduction level. All right, so continue the flap until you've exposed the tissue apical to the level of bone reduction, which you can just watch, visually looking at the fixation base. All right, and then an optional suture, hold the tissue back, very common. All right, next step, bone reduction. Doctor uses what we call a Mr. Hungry burr. It's a burr from Comet, and it's very aggressive. And so bone reduction can, especially on an edentulous case, can be very, very quick, just minutes, and you're done. Move on to the next step. You can see the aggressiveness of that burr. All right, so you're going to flatten the bone right to the fixation base, and with an aggressive burr, it's easy to get a little bit too aggressive with the bone and reduce it too much. So you almost have to hold it back, especially this burr, because it's so aggressive. But just visually watch, looking down on the patient to make sure that the bone is flat and even, as if it's a flat plane, even with the fixation base. And it's important that it's flat, because the next step is to put the carrier guide in to test to make sure the bone is flattened. I think Dr. O will probably try it in. We'll see here, but that's one of the tricks, especially if you're not sure if the bone reduction is perfect. You try the carrier guide in and make sure that it seats passively. More, there you go. All right, so this is the pre-check. Seat the carrier, plunge in the chrome locks, make sure it's passive. You don't want to force this at all. If you're forcing it, that means there is tissue or bone in the way, and you'll remove it, and you'll either adjust the bone or maybe a suture, maybe spatula the tissue out of the way. All right, so we know that it's passive. It's going to come out. A little bit of adjusting. Now, doctor uses I believe some Pico spurs here to round off the sharp edges on the lingual and the facial, buccal facial areas, to round off that bone so it's not so sharp under the tissue later. Even between the fixation base and the bone, he's going to round off those sharp spires that are there. All right. Osteotomy guide then goes in. Won't go through the drilling protocol, but essentially drill all your sites, put your implants in. And one thing to be aware of is that the metal with chrome is it's not forgiving, right? So if you find yourself drifting a little bit with your drills or with your profiler or with your implant mounts, and you get stuck and you're torquing out, then you can always release the chrome locks, and that'll remove all the friction and then take the osteotomy guide off. And while you're doing that, your component will also come, your tool will also come off, right? So you don't have to use rongiers and pull tools back out of the osteotomy guide. Just click on the 3 chrome locks and loosen it up. That removes all the tension. All right, so doctor's going to go through the protocol. We'll just fast forward through all this. All right, implants going in, implants in. A little bit of bone profiling. Now it's recommended to have a bone profiler, but if it's a matter of putting a cover screw on, freehanding the bone profiling, it's as they say, Bob's your uncle. Whichever works out best for you to ensure that the bone is cleared so that you don't have any hang-ups with your angled multi-unit sites. Follow whatever pattern you'd like. All right. With all the implants in, the bone profiled, the carrier guide goes in, and the carrier guide is going to support the prosthesis. It is going to give an indication of where the screw is for the angled sites. You can see the little, let me just go back here a tick. The black marks here show the angled sites. So this is straight, and angled. And that little notch, the black line, the notch, shows the trajectory of the abutment screw that's going to go into the implant, and it shows the trajectory of the implant where the driver goes in, everything. So just imagine the screwdriver going through the notch, into the screw, into the implant. That's the visual you'll get when you're seating your multi-unit abutments. All right, you can kind of see it right here. There. All right, so it's a little bit of a funny angle with the camera, but if you were looking at it from this trajectory, that shaft would be right in the middle of that notch, and you know your implant's in the right position and your abutment's seated in the right rotation. All right, and then just simply repeat. And these are all straights, those go in very quickly. Straight, no problem. And now a doctor is checking to make sure that there's passivity on the temp cylinders. All right, so he's a little bit ahead of most of our videos, and that's okay. He's trying in the rapid appliance, and he has a little technique where he opens up the rapid appliance a little bit more than typical because he wants this process to go fast. He does hundreds of cases a year. So he wants his process. So he opened it up, but still, he's checking to make sure that there is no contact between a temp cylinder and a rapid appliance. All right, remove it, put the gaskets on for block out. All right, seat the prosthesis again, and then backfill. A doctor performs so many of these cases, he doesn't use the little blue plugs. And frankly, they won't work in here because he's using more of an impression post than a temp cylinder. So it's a little variation of it. But if you watch our other videos, you'll see the blue plugs here for blockout. And once you do a lot of these cases, you'll find that backfilling around the temp cylinders is pretty easily accomplished, and you won't get material down the temp cylinder where the screw is. But our recommendation is to always use the blue plugs. All right, so backfill, hit it with a light. He uses stellar every time, so he's hitting it with a light, cures in 20 seconds. All right, now prosthesis is fully cured to all the temp cylinders. Unscrew each, remove the rapid appliance. And the nice thing about this technique, this small hole technology, I know I haven't mentioned this during the meeting, but during the program here, but doctor performs an extra oral conversion, right? So most of the time, standard chrome, you're picking up 2 prosthetics in the mouth and luting them both in the mouth. One for the patient to wear home, and then one as a backup and for you to use at the time of restoration in a few months. But with our C2F small hole technology, doctor is going to take this rapid appliance and plug it into a model back in the lab, and he and his team are going to quickly convert the take-home prosthesis and then drill little holes in here, little 2.7 millimeter holes as opposed to these large holes. It's a really wonderful technique, but we won't cover that today. We're just going to cover this surgical process. All right, so chrome locks are undone. The carrier guide comes out. And then the fixation base will be removed. Okay, one thing that Dr. O does is that he will remove the carrier guide and then seat the prosthesis. This is where he will visually confirm that it is seated, that he picked up all the temp cylinders, that there was no gapping or hang-ups anywhere. So this is a visual. He's looking down between the prosthesis and the fixation base. He's making sure visually that those temp cylinders are down, make sure there's no rocking, and then he'll take it out and go back in the lab and do his C2F conversion. All right, pins are out, and then go through suturing. Always put some comfort caps or some kind of healing collar on there, a suture collar, and then suture it up. We won't go through suturing techniques. All right, so we are at 1 hour, which is very typical for Dr. Olson. He has lectures on the 55-minute chrome arch surgery. All right, from cut to suture. All right, now going to begin the lower. The lower is different because it's a dentate. This follows our normal protocols, which are try the pin guide in, make sure it fits, it doesn't rock. Then lay your labial flap. Labial buccal flap all the way apical so that the fixation base seats and the tissue will be apical to the fixation base. So sorry, I'm just going to kind of fast forward through this part here. Now, this part is similar to the upper, where the pin guide is held firmly. Now the patient's open, right, because this pin guide does not have occlusion on it. And the team, you can see the pressure on that thumb. All right, now normally it's 2 or 3 fingers, but this patient, the patient has a lot of teeth, and so just holding it firmly to all the teeth is fine. And doctor follows the same protocol. Drill a hole, pin a hole. Drill a hole, pin a hole. And you'll see that when he drills these, he is not leaving the pin out as far, right? Because this is the mandible and the bone is much more dense, so you should not have to tap quite as much. All right, so there we are. Go back a little bit. There we go, tapping him in. Surgical mallet, and especially on dentate cases, you will hear the noise. Totally different noise from tapping a pin to tapping a pin once it hits the metal. It's more of a dull sound. All right, so as soon as the pin hits the metal, you're done. All right, nice and quick. Chrome locks are detached, disengaged rather. Pin guide is removed, and doctor will proceed with extractions and bone leveling. Now, very typical, the doctor is going to break the seal between the bone and the teeth. Very, very common and advised. Breaking the CEJ, breaking the contact, so that making every effort to not break the buccal bone. All right, so this few minutes, several minutes of adjusting, grinding away that connection area is critical to saving the buccal plate. All right, and even making some separation between the teeth so that they can move in different directions. All right. Won't go through much tooth extraction. We have tooth extraction experts here watching this. Okay, very typical action here. Then you can decide if you want to go after the roots now, go after the roots in a little bit. But typically all the work is done here. Extraction, bone leveling, pick out any root tips, and then just make sure that the bone is completely leveled down to the fixation base. And then again, you'll need to do a lingual flap before taking a burr to the bone. Here it is, Mr. Hungry. Flattening, always watching, and this is where the team can really help too. They can observe, if you wish, they can observe where the bone needs to be reduced, because looking at it from different angles as you move around the mouth, left, right side of the patient, you can see a different perspective of where the bone needs to be reduced. All right, and then once you think you've accomplished the bone reduction, then you will try in the carrier guide. Sorry, let me get to that point. Missed it. Try in the carrier guide, and you can also try in the prosthesis, make sure everything looks good. I know sometimes doctors will seat the upper prosthesis, and then while they're performing the lower surgery, you can seat the rapid appliance or seat your prosthesis and check the bite while you're in surgery. And that way, just in case there's any issues at all with the bite, you can make little changes while you're doing the pickup. But he's now just verifying passivity with the carrier guide and that the prosthesis is seating, kind of like just a pre-check, no surprises when it's time to go to do the pickup. Because you don't want to have to adjust bone after the implants are in, after you're all ready to pick up the prosthesis. You don't want any surprises. All right, so this is just going to be obviously a repeat of the upper. I'm just going to go quickly through this, put the implants in. All right, implants, carrier guide, multi-unit abutments, following the same protocol on angled sites. He's got 1, 2, 3, 4 angled sites and 2 straights. All right, so it's really critical to turn the implants, and I'm going to go back here a little bit. I'm going to go back and have a look at the indexing on the osteotomy guide. Let's just go back and cover a little bit of implant indexing, because it's so important that the implant is in the right depth and the right angle according to the plan, right? Because you want to have a temp cylinder that's in the exact right position to go through the prosthesis, because it's all predetermined. Implant rotation, depth, angulation, multi-unit abutment, hole in the prosthesis, all that is predetermined through the workup. Of course, you can deviate just a little bit, but in order for it to go smooth, you really want to follow the plan. So when we make the osteotomy guide, you'll see that there are nubs. There's 6 of them on each of these sleeves, and the nub will align with a indicator on a mount. There'll be a vertical line or a color or a notch, or there'll be a dot, and that is what coordinates with the nub. You'll line them up and just follow the rules, because they're all a little bit different. But there's also the depth marker. So there's a depth marker that stops at the top of the sleeve, and there is a marker for the rotation. Now, Dr. Olson, as you may have seen there, that was a basically a non-guided driver, and then he follows up with a guided driver. All right, so this is a straight site. There's no nub. All right, so he can just drop that implant in until he's happy with the depth, and he can follow the line. You can see the line there on the mount that's going to stop at the top of the sleeve, and then he's basically done. All right, but on an angled site, he would have kept rotating until that line was perfectly even with the top of the sleeve and the vertical mark was even with the notch. And then as mentioned before, if you get a little bit of tension on the osteotomy guide because of deviation, and you can't get the mount out, then just simply unclick the chrome locks, loosen up the fixation base, like so. All the tension will be released. Most of the tension will be released, and then you can remove the osteo guide and the mount at the same time. There you go. Now just click it back in and then get started again. All right, so let's fast forward back to the carrier guide. All right, the carrier guide was tried in, but then Dr. wanted to go back and do some bone profiling. So a little bit of profiling, typical. I think he tried that multi-unit abutment in, and there you go. All right, so the angled sight's going to go in. There we go. All the temp cylinders are added. Carrier guide goes in. 1, 2, 3, 4 angled sights and 2 straights. This should be very passive. Be sure to move the tissue out of the way. That's often the problem with it not seating easily. Click in the chrome locks. Try in the prosthesis, make sure it's passive, no issues. Take it out. Install the blue blockouts. And then backfill around each of the, in this case impression posts, but around the temp cylinders. Unscrew, remove, and then if you'd like to come back after taking the carrier guide in, put the prosthesis back in to make sure that it's perfectly seated and passive. It's a great idea. I know Dr. Olson calls this the parachute test. Don't jump out of a plane without a parachute. So this is making sure that he's not going to have any issues seating the prosthesis. All right, prosthesis goes back into the lab, do the C2F small hole conversion, and suture the patient. All right, and then again, we won't go through the whole suturing process, but that is the surgery. And then Dr. Olson and team seated these beautiful prosthetics. You can see you can't even see holes because he uses this small hole technology. All right, so uses some nice composite, fill the holes, and then a few weeks later, nice photos taken. Great work. Before and after. All right, so patient has been healed. Patient went through this whole process, and 4 months later, patient comes in for final restoration. All right, so what doctor will do, and there's a couple of options here, but the protocol that we recommend is a little bit different than this one. This is a little bit of an older protocol, where the rapid appliances are seated, do a wash impression, bite registration, photograph, send to the lab for a prototype. But let's look at this restoration here. This is what the patient is wearing for months. It's what they like. The bite's worked out. Everything is worked out about this case. I mean, there's going to be some aesthetic changes, right? Midlines are going to change a little. I'm going to work with a little bit of the overbite, overjet, that kind of thing. But essentially, the patient's probably liking this a lot with a few cosmetic changes. So rather than send the rapids in, send the patient home in the rapid appliances. Now, he opens this up. It's atypical that it would look like this. This works for his protocol. But the rapid appliances should still be intact, and they're going to look very much like the surgical prosthetics. They're going to be beautiful. They're going to seat, patient can wear them home. and take these surgical prosthetics, take these out of the mouth with a wash impression and a bite, and send them to the lab. And then your laboratory will really be prepared to make a prototype and then go to final. All right, so nice, beautiful wash impressions underneath, bilateral bite registration. Don't just take a big bite around the whole roundhouse. You want to make sure the patient's coming together perfectly. All right, and then make your final prototypes. Maybe even go direct to final restoration, depending on, you know, the quality of the records. What I mean is that the patient likes what they're wearing, and you're very close to a final. You could go right to final, but typically there's a prototype or two, depending. And then this is still temporary, but the patient's finalized now. Forgive me, I don't have the final restoration. Actually, you know what? I think those actually are final restorations, but that's okay. I won't attest to those being or not being finals, but the patient's delighted and really appreciate Dr. O for sharing all this documentation with us. And that is an upper denture with a lower dentate, so Edentulous against dentate treatment protocol. Thank you.